Now we're going to move on and talk about injuries to the nervous system that happen lower than the brain. So primarily we're going to be talking about spinal cord injury. So this would be injury somewhere in this region where the spinal cord has been severed. The brain is functioning fine, but signals from the periphery below the injury can't ascend to the brain where they're interpreted, and signals to the brain can't get out to the periphery. Now, there's some vocabulary that you should be familiar with. Tetraplegia means that there's a functional impairment in all the extremities, the trunk, the pelvic organs. This is typically an injury to the cervical spine. It used to be known as quadriplegia. Now it's more known as tetraplegia. Paraplegia is motor or sensory loss in the thoracic, lumbar, or sacral levels of the spinal cord. And this will typically involve paralysis or problems in the lower extremities, but the upper extremities are functioning fine. Now, in addition to that, you can also have a complete injury, which means the spinal cord was completely severed, so there's no sensory or motor function below the level of the injury, or an incomplete injury where it was just partially severed, and there is some preservation of sensory or motor function below the level of the injury. So you could have a tetraplegia that's complete, meaning there's no function below the cervical level, or incomplete, which means there is some preserved function. So the same thing is true with paraplegia. You could have a paraplegic that's either a complete or an incomplete. Now, one of the studies that we conducted, we wanted to look at how much impact does physical activity have on quality of life for people following spinal cord injuries. And this is the graph that we were able to put together in this study. So you can see that as level of physical activity increased in this population, so did quality of life. So physical activity and exercise becomes a very important component of life following a spinal cord injury. Now, what we know is that for every level of injury on the spinal cord, there are certain physical functions that are associated with it. And everything below the level of the injury is where the impairment will be. So the higher on the spinal cord the injury occurs, the greater the level of impairment. So I will not expect you to remember specifically what's innervated at each level, but I do want you to be familiar just with the pattern. That if you have somebody that has a high cervical injury, they may not even have a functioning diaphragm and they'll be on a respirator. And if you can just spare those levels, they'll be able to breathe independently and perhaps move their shoulders, which would be a big improvement. If you can get all the way to C6, then you have function of the elbow, the shoulder, and the diaphragm. And each level that the injury descends on the spinal cord, the more function you get. If you can spare T1, that's the last level that contributes to function of the upper extremities. So that's the distinction between a paraplegic or a tetraplegic. And if you get down here into the sacral region, you would only damage things like bladder control, bowel, sex organs, those types of things, which is still a very significant impairment. It's just better than losing breathing. Now, you're going to have a variety of impairments that are associated with this type of injury. You're going to have some level of paralysis where the muscles aren't working. And if it's high enough, breathing may be compromised. You might have a situation known as autonomic dysreflexia. And this is where some sensory signal just turns on the autonomic nervous system in high gear, and you get a very dramatic increase in blood pressure and heart rate, and it puts people at a very high risk for a heart attack or a stroke. And it's very dangerous. So you really need to watch blood pressure in heart rate if you're doing any activity with this population. So this is a dramatic rise in those variables. You can also have hypotension, and this is the opposite of dysreflexia. This is a dramatic drop in blood pressure where the person is likely to pass out. And typically it's when you have somebody that has not been standing and you put them in an upright position and the blood pools in the lower extremities, there's not enough blood being returned in circulation, and they're going to pass out. In this situation, you would want to get somebody upright, hoping that you'll decrease the blood pressure. In this situation, you would want to put them in a lying down position in order to try to decrease the blood pressure. Pressure sores can develop. If you have somebody that's sitting for a long time and there's something either pushing on their leg or in their seat, they're not going to be able to feel it, so that this could cause a skin breakdown and a sore that's very difficult to heal. Certainly there's going to be problems with bowel and bladder function, and that needs to be taken into consideration if you're working with this population. They may have problems with temperature regulation. They may have some neuropathic pain that prevents function. They are going to have a blunted cardiovascular response because the brain isn't going to know that the muscles are working, and you may even have a problem in the cardiac accelerator nerve that you can't even get an appropriate heart rate response. They may fatigue quickly because, again, they're not getting good circulation. They can have spasticity as well. And they're also at high risk for developing deep vein thrombosis because they're not contracting and relaxing the muscles of their legs. They can have heterotropic ossification, which is where their osteophytes form in the joints and limit motion. And then certainly there would be some psychological adjustments, as you can imagine, if you were walking around one day and then you find yourself in a wheelchair the next. Now, short term, you tend to see fairly quick improvements in both sensory and motor function, and this is because of something called spinal shock. So there's a lot of inflammation that occurs right along with the injury, and as that resolves, as the swelling goes down, you may find that some of the impairment was just from the swelling, not from the actual injury to the spinal cord. So somebody who initially may have been diagnosed as a complete, after the spinal shock resolves, you may find is an incomplete, and some function was spared. Most motor and sensory return in both complete and incomplete injuries will occur during the first 6 months after the injury. So like I said, the short-term prognosis, things are going to change quite a bit. Now, if it is a complete injury, it's more predictable because you know what won't be able to return, because you know the spinal cord was completely severed. Now, the long-term prognosis is much slower, and you're going to see minimal changes after 1 year. Functional independence will improve, even if neurologic recovery is not. The patients get to know their abilities better. They become a little bit more confident, and they're able to do more. And certainly the prognosis is better for people with incomplete injuries than it is for complete injuries. It's important to remember in all of this, though, everybody has potential to improve. And as family and patients want to hope for recovery, it's important to maintain hope while planning a realistic course of action. So we don't ever want to say, we don't think somebody can do this, but at the same time, we don't want to put them in dangerous situations or not recognize the severity of the injury either. So when you're working with this population, first, you really do have to establish rapport and some trust. You're going to ask them to do some things that are difficult, and they've already been injured and are going to be apprehensive. So really establishing a relationship is going to be important. And to teach the patients or your clients about their potential for function, what can return and what have you seen in the past. And this comes with some experience. and learn about who they are and what is important to them. It's going to be more beneficial to work on tasks that are important to the client. And just always consider that they are going to have a blunted cardiovascular response and be able to plan for that. And then just always think in terms of how can you adapt something? If this is something they want to do, how can you make that happen? So some areas that you will want to work on is definitely strength. And this would be both in the impaired as well as the non-impaired muscle groups. What has been spared is going to have to take on more activity to compensate for what was lost. So even the muscle groups that were not impaired are going to need to be strengthened. But anything that you can do to strengthen the muscle groups that are impaired will certainly help increase their function and take the strain off of the other muscle groups. You definitely want to work on bone density and bone loading. This is one of the primary issues related to fractures in this population. Because those joints can get those osteophytes formed in them, flexibility and maintaining that from the start is very important. Balance is an issue as they're not getting as much feedback. Teaching some balance maneuvers will certainly help improve function. You want them to be able to transfer safely, to be able to move from one surface to the other. It opens up a lot of possibilities if these clients can learn how to get in and out of a car or in and out of the wheelchair on their own. Now, you definitely want to work on endurance. And it's difficult when only the use of the small muscles are going to be able to be used. If you could only use the upper extremities, it's hard to increase VO2 max. But if you can work on any kind of walking or full body motions, it's going to certainly help. You always need to consider pain and what activities increase or decrease pain and what their pain level is at a particular time. Be very concerned about weight. You have, once somebody's injured and they are now in a wheelchair, they have been sentenced to a sedentary lifestyle for the most part, and weight gain and the associated problems with that can contribute to a variety of health issues down the road. So you really want to try to maintain their weight and always watch their blood pressure, because as I said earlier, you can have a situation where they're getting extremely high blood pressure or very low blood pressure, and both would be dangerous. Unfortunately, there aren't currently any published consensus on recommendations for developing exercise programs for people with spinal cord injury. So pretty much you're going to have to assess what the client's goals are and then figure out how you can make those adaptations, increase accessibility, and decrease barriers so that they can achieve their goals. Now, the typical population for spinal cord injury are young males. And so you typically have a population of people that were pretty healthy. So it's not unusual to try to follow the guidelines for healthy adults, but just with the special considerations related to spinal cord injury. So you always want to make sure that you have them empty their bladder prior to exercise, and that will help avoid that any problems once they're exercising. You want to make sure that you're avoiding any pressure on their skin. You want to monitor heart rate and blood pressure so that you're watching for the symptoms of that autonomic dysreflexia or orthostatic hypotension. You want to start with short bouts and give them rest periods and see how they're doing, and then move on from there. And you might consider some kind of compression, some compression garments or socks, something like that for the lower extremity, or even using electrical stimulation to try to keep the circulation from their legs moving back to their heart so that they can increase their stroke volume and stay active for a little bit longer. Always try to include non-wheelchair activities if possible. They can continue to do wheelchair activities on their own, but if they're working with you, then you want to try to get them out of the wheelchair. That'll help take pressure off, increase their range of motion, and just make them aware of their function without a wheelchair. Always try to protect their shoulders because their upper extremities are now their primary muscles of mobility. And if you damage a shoulder, then they have a lot of difficulty moving. Tenodesis is a functional grasp that is done just with movement of the wrist rather than movement of the fingers. So you can look for that. Watch their temperature tolerance, because as I said, a lot of times you're not going to get a sweating response because you're not getting good sensory input. And then just watch stretching precautions. Like I said, if you're working with somebody who's been in a wheelchair for a very long time, their bones are going to be like matchsticks. And if you put too much force on them, stretching them, you can fracture a bone. So the bottom line in all of this is that proper exercise and physical activity will reduce the prevalence of secondary complications and will improve quality of life following spinal cord injury. And if this is a population that you're interested in at all, we do a lot of work in the lab with people with spinal cord injuries, and you're welcome to join us sometime to observe some interventions and exercise once we get back on campus and can start having people in the lab again. Thank you.